Why don't we go ahead and get started? We've got some good cases for you guys this morning. I think you'll enjoy the session. This is a really beautiful case here. So anybody want to give this one a go?
Hi, Dr. Cockrell. I'll take this one.
Okay.
So this looked like an excision to me.
If you're going to give this a grade of A through F, what are you going to give it?
Like for the level of bad, like what it being a bad thing, or sorry.
Bad or good, based on
I think it's bad.
bad.
I'm worried about it.
Well, you're worried about maybe the diagnosis good, but look, I was just talking about the biopsy. I mean,
beautiful excision.
Yeah, this gets like an A plus.
Yes.
What's interesting though, if you look carefully, what do you think happened here?
I was thinking that was the process, like sparing the superficial dermis.
I wish it were, but actually, you know what happened here, interestingly enough, this was a bad biopsy. This was an original shave biopsy that they just barely got into this. And then we kind of suggested that maybe it was the surface of something else. And guess what? Then they went back and took a complete excision of it. So it just shows you what the problem can be with superficial shave biopsies. And everybody likes to do them. And maybe to their credit, maybe they thought it was a basal cell or something like that. It's perfectly fine if you think it's a basal cell or a benign nevus or, fibrous papule. We're not saying that you should do deep excisional saucerization biopsies of everything. But if you're dealing with kind of a large lesion, you kind of run the risk of missing it. And they did miss it here, as you can see. They just barely got into something. And then we said, be careful, and went back and re-excising. And now we've got an obvious situation, right? Mm-hmm. Which you don't like.
Yeah. So I felt like even just from this low power view, I could see what I felt like were lymphoid aggregates in the derm all the way to the subcutis.
Okay, good. So lymphoid lesion. Now, when you're dealing with lymphoid lesions, what are the two major categories that we have to deal with? Just like we're dealing with melanocytic lesions, we have two major categories, right? We have melanoma and nevus. When you're dealing with lymphoid lesions, what are the two major categories you have to deal with?
So like lymphomas or they're inflammatory.
Good, excellent. Like a lymphoma versus a pseudolymphoma kind of lesion. Okay, good. Now, that's not always easy to tell them apart in every single case. But here, what criteria do you generally use for distinguishing between lymphoma and a benign pseudolymphoma? What are some of the things you look for?
Yeah, I know for like pseudolymphoma, sometimes the endothelial cells may look more plump or be hyperplastic.
See that, yeah, if you're like looking in the germinal centers, but that's kind of a relatively obscure finding. If you're looking at it at this power, and you've got a mean teacher that's refusing to let you go to higher magnification, like me, what kind of architectural features would you look for, say, in a pseudolymphoma versus a lymphoma?
So looking for like the actual germinal centers.
That's one thing that can help you. But what are some of the most common causes of pseudolymphomas that we see? What's probably the most common cause?
Like Lyme disease or like the tick bites.
Yeah, like a bug bite. Exactly. So what happens? Yeah, they're exactly right. Somebody gets a bug bite, they get a hyperimmune reaction to it. And if you look at the pattern of a bug bite, what's the most common histologic pattern we see in a bug bite reaction, arthropodosol reaction?
Usually eosinophils.
You do see eosinophils. It's usually a superficial and deep wedge-shaped trait with eos, like you mentioned. And then if that kind of goes on and the immune system gets sort of turned on because the person's got an abnormally hypersensitive reaction to it, then that wedge-shaped infiltrate becomes more nodular. But then you start seeing the germinal centers, the eosinophils. And would you expect to see these kind of germinal centers are sort of floating freely on their own down here in a pseudolymphoma?
No,
not at all. That's be very unusual to see that. Yeah. So that's one thing that, unfortunately, today, with the advent of all these molecular genetic testing things that we have available to us, there are a lot of pathologists that don't even really look at the morphology. And, I was actually working on a project with a guy a few years ago, just to say, let's see if we can just make a textbook or an atlas or something, just talking only about the morphology of cutaneous lymphoid lesions with no stains, and the stains and the molecular stuff should be sort of adjunctive. Today, they sort of have almost taken a front row seat, and they're helpful. But, when you look at something like this, you should say, this doesn't look like any typical pseudolymphoma at all. You're exactly right. Now, if you're going to define this as a lymphoma, what are the two major subtypes of lymphomas that we deal with in dermatopathology?
Either B cell or T cell.
Good. Excellent. And which subtype would this be?
I thought that this was one of the B cell.
Good. B cell. Whenever you get like a germinal center formation like this, or they're recapitulating germinal centers, that's a B cell pattern. You don't see that in a T cell lymphoma. What's the most common pattern we see in T cell lymphomas? There's several patterns, but what's the most common that we see in dermatology?
So, like more diffuse.
Well, what's the most common cutaneous T cell lymphoma?
Oh, like mycosis fungoides.
Yeah. So MF will tend to give you this kind of band-like infiltrate with epidermotropism. So it kind of likes the epidermis, and it also likes the subcutaneous fat, interestingly enough. Like subcutaneous paniculitis-like T cell lymphomas. So just think of T cells as sort of being like clingy. They like to cling to the epidermis. They like to cling to the subcutaneous fat. And then sometimes you get this, you can get a nodular type, this so-called CD4 small to medium-sized lymphoproliferative disorder, which really isn't even considered a T cell lymphoma anymore. It's sort of like a T cell pseudolymphoma. That pattern can be more nodular in a way, but doesn't give you the germinal centers. So when you see germinal centers like this, you say, if it's lymphoma, it's almost certainly going to be a B cell lymphoma. Now we'll go to higher magnification. And so, do you know anything about B cell lymphomas? And today, as dermatologists, we really should know more. When I was training, we sort of thought, B cell lymphomas, we'll just toss that into the categories and send that to the hematologist and the oncologist. But why is that not a good idea to send them to the hematology and oncology most of the time?
Well, I mean, like when they're just localized to the skin, we can treat with like things like radiation or.
Yeah, exactly. Or excision. They're very, very indolent in most of the B cell lymphomas. So there's the two main types that we see are, do you know what those are? The two main B cell lymphomas that we see? You may or may not. If you don't, that's okay. But there's two types. This is one of the types.
Like either mantle cell or follicular or follicle center.
Yeah, follicle center cell. And the other one is marginal zone lymphoma. Those are the two main types we see in the skin. Occasionally, we do see the mantle cell. Those are usually associated with patients that have a systemic mantle cell lymphoma that spreads to the skin secondarily. So those are usually a little bit worse prognosis. They're usually not primary lesions. But the two primary B cell lymphomas, the three, are follicular center cell lymphoma, follicle center cell lymphoma, marginal zone lymphoma, and then the large anaplastic B cell lymphoma, the leg type. Those have a very bad prognosis. So those you don't want to miss. And those don't give you these dermal centers like this that look well defined and whatnot. So they give you more of a diffuse pattern with lots of atypical cells in them. So those are the three main types of B cell lymphomas. And don't fire them off to the oncologists, because they may put them on chemotherapy. Some hematologists, oncologists don't understand that this is just a benign localized cutaneous lesion. What's the long-term prognosis of a marginal zone lymphoma or a follicle center cell lymphoma that originates in the skin?
Usually pretty good.
Bet it's good. It's about 95%. Marginal zones, about 100% 5-year survival. So, in the old days, years ago, we used to call a lot of these pseudolymphomas because they really didn't have any bad prognostic features. In fact, they used to call the marginal zone lymphomas semi-malignant lymphoma or immunocytoma, because they have a lot of plasma cells in the lesion. Occasionally, we would see as time went on, and they developed genetic testing, they would show that there's clonality. And then they show that occasionally a patient would develop metastasis from one of these lesions. And I've seen that happen over the years in my career. Rare, but it does happen. So they probably really and truly are lymphomas, but they're low grade. And so you don't want to, send these patients off to get chemotherapy. That's going to be more damaging to them than just treating them conservatively. So this is a B-cell lymphoma. And which type would you say this would be most likely to be?
I thought this looked like the follicular
Good.
lymphoma.
Exactly right. And then one of the characteristics we talk about in that lesion is the so-called inside out germinal centers. Normally you see a germinal center, you've got a nice little round collection of centrocytes, and then you get the marginal zone of those lymphoid cells at the periphery, the lymphocytes at the periphery. Here you've got some of these pale germinal cells that have broken through. There's not those cells at the periphery all over this thing. These cells are outside that. And sometimes you'll even see an area kind of like this one where it's almost purely the follicle centrocytes here with no lymphocytes aggregating to it. So when you see that pattern, very, very characteristic of follicle center cell lymphoma. Just think about that inside out, like the little Disney movie Inside Out. Well, you're thinking about inside out germinal centers, think of follicle center cell lymphoma. And has very, very good prognosis. You can do stains for this. This will stain positively with CD10 and also BCL6. If you stain it with BCL2, some people say, that means it's secondary cutaneous spread. That's not always true. And BCL2 will highlight T cells. So a lot of these cells around here are T cells also. When I was back in my training, we'd say, well, if we do CD20, and if it's all CD20, it's possibly a lymphoma. If it's got CD3 and CD20 in it, well, it's a pseudolymphoma. Wrong. So we know that these lymphoid lesions, B-cell lymphomas, have a lot of T cells in them. In fact, in the old days, we used to call that T-cell rich B-cell lymphoma, but now we know it's kind of common. It's rare to have purely B cells in these B-cell lymphomas. But if you get most inflammatory skin lesions in the skin are T-cell. So if you see a lot of B cells and germinal centers like this and whatnot, unless it's really a classic sort of pseudolymphoma with eosinophils and everything else, you really need to be thinking that it's possibly one of these lesions. And you don't have to say, oh my God, the patient's going to die, that sort of thing. They generally have a very good prognosis. Radiation therapy, like you said, is good. Sometimes excision. A lot of times these lesions disappear after the biopsy. You can even inject high-dose corticosteroids into these sometimes. So they tend to be very good prognosis. And you mentioned tick bite and whatnot. They're actually this follicle center cell lymphoma and some of these lymphomas, at least in the European literature, have been associated with Borrelia infections. So that's something just to know about for the board examination. So good example, beautiful example of that lesion. You don't usually get, we usually get those shave biopsies, unfortunately, those, which we really don't like. All right, somebody want to try this one?
I'll do this one. Good morning. So it looks like we have a really deep puncture excision, and I'm leaning towards a neoplasm.
Yeah, good. Excellent.
We have some nodules in the dermis or sub-Q down there.
Yeah, this is a pretty deep lesion. They probably thought it was, what do you think they probably thought this was?
Maybe a cyst?
Yeah, exactly. 99.9% of the time when we see these lesions like this, it comes in as a cyst. And this one actually has got a cyst kind of component to it. A lot of times, though, there's no cyst to it. It's just not a solid lesion or something like that. They think it's a cyst. Beware of the diagnosis of cyst. Don't throw cyst away. And I mean, if you cut into it, it obviously smells like Swiss cheese and all this kind of stuff, maybe. But I'd recommend sending something in just to document. I've seen necrotic tumors look like cysts histologically and clinically, and I've seen metastases of lesions look like cysts. I've seen lots of adnexal tumors look like cysts. I've seen lots of desmoplastic melanomas, interestingly enough, look like cysts. So it gets signed out by good clinical, diagnosed by good clinical dermatologists as cysts. So cyst is often a wolf in sheep's clothing, so beware of it. So you think this is a neoplasm? You think it's benign or malignant?
I think benign.
Good, excellent. Pretty well circumscribed. They were able to probably either deep punch it out or excise it out pretty well, or goes to the base. And do you think it's epithelial or non-epithelial?
Looking at the lining of the cyst, it looks glandular,
Okay, so, and if it's glandular, then it's
epithelial.
epithelial. Good, so that's a type of epithelium. And what kind of glandular?
Um,
Gonna add here.
so this looks like there's some of that decapitation secretion.
Excellent. This is all the decapitated secreted material in here. That pink stuff here is all protein from this. So that's good. So that's apocrine decapitation secretion. Good. So it's a benign adnexal neoplasm with apocrine differentiation. So now we've decided that. So we're 99% of the way through here. We're home free. How do we name these lesions? So we say, okay, it's apocrine. How do we give it a name? So it's like if you have a baby, you want to give it a name? How are you going to give this thing a name here?
Well, it's benign.
Good. Good.
So possibly an apocrine adenoma.
Okay, there's an adenomatous component. I agree with you. What else is characteristic of that we talked about?
The cystic space.
Got a cystic, so you want to throw cystic in there. So we got benign, adenoma, we want to toss that in. We got cystic in there, we're going to toss that in. And then what's the last thing we might want to throw in here? What about these little frond-like structures?
Are we thinking a hydrocystoma?
Well,
Or sorry, I was thinking tubular apocrine adenoma was my first thought.
well, tubular apocrine adenoma, there's this, and and these are fine points, okay? They're not going to get counted off if you were to say that. But tubular apocrine, think of tubules. You got lots of little tubular apocrine adenoma is almost kind of like, sort of like a syringoma, but you've got lots of apocrine little syringomatous-like lesions. Here, you've also got these frond-like lesions. So what do we, when we talk about sort of things protruding into the lumen and they kind of have these little frond-like structures, nipple-like structures protruding into the lumen, what do we call that?
Papillary?
Papillated. Good. So now put it all together.
Papillary
Papillated, apocrine, cyst, adenoma. See how it works?
Got it.
You just take all the elements and throw them in there together, and then you got a name. So it's not if you got a benign apocrine neoplasm here, I'm fine with that. But if you want to just kind of be more of an expert at it, if you will, that's the way to name these things. So we sort of look at what the components are, and then we just kind of put it together. So that's good. Excellent. That's precisely the right answer. So you hit the nail on the head, and it's totally benign lesion with apocrine differentiation.
Thank you.
Any questions about this one? Okay, good. All right, we'll move on to this one. This one's kind of interesting. Okay, this one's very interesting. As a matter of fact, I actually encountered this years ago when I was a very young, right out of fellowship, junior faculty, had just moved here, and I got a biopsy that showed this kind of thing. So it kind of was a challenge at the time, that 40 years ago.
I think it was still a challenge today, but let's knock it out. So I think we have a punch excision of a cyst.
Good. What I had at the time was a shave, and it just kind of showed mostly this stuff. But you do have a better biopsy that's actually got the entire thing out of here, so that's good. So you're not going to make you're not going to have the difficulty that I had. And the guy that the biopsy came from was a billionaire with a B.
Whoa.
So it's like pressure's on. You don't want to miss a diagnosis in a billionaire, right?
No.
You guys have heard of the Hicks Muse? Multi is like a hedge fund kind of thing. And this guy was very, very wealthy. And I got this biopsy back in 1989, I guess it was. It was a superficial shave biopsy, and it just showed only this dark material here. So guess what I was worried about?
Melanoma.
Yeah. Yeah. Superficial shave. Oh my goodness. I want to make sure that I don't miss the diagnosis of melanoma in this famous billionaire guy. So, but you got a good biopsy here. So you don't have to
Well,
worry.
I think it looks like another epidermal cyst. It has nice squamous lining. It looks like it has a granular layer, so I thought it was like a follicular infundibular cyst.
Well, what about how thick is this lining here?
It's really thin.
Is that common for follicular cysts to have that kind of lining?
No.
No, it's not. It's not. And so if you look really, really hard, really carefully, you can see that there's basically, this might be a little clue. You know, what do you think that is actually?
It's like a basaloid cells.
Well, and here's another little clue. So let's look at this one. Look right in this, well, actually, that's not as good. I thought it was, but that's a follicle. This is probably the duct of an eccrine gland heading up towards the epidermis. So we've got it, you know, it's coiled, right? Like a spiral. So we whacked it here. We got it in cross section. And so it's related to this. And notice there's one cell layer, cuboidal cell layers, one single cuboidal cell layer here. So if that's associated with this acrosyringium, and this, beneath it, it's kind of formed a little cyst, what kind of cyst do you think this might be?
An eccrine,
Yes, eccrine. Keep going.
like a hydrocystoma.
Hydrocystoma. Good. Now, why was this challenging to us when we saw this black material in this billionaire? Why did I get worried?
Well, it looks like pigment.
It is pigment. So what's your differential diagnosis of pigment that's dark in the skin?
I usually think of some kind of melanocytic lesion,
Melanin.
nevus,
Yes.
or
So we're
malig-
just thinking the differential diagnosis of dark pigment in the skin. So one is melanin.
Mhm.
What's the other most common one? Is the second one that's very common that we see.
hemosiderin.
Good, excellent. Hemosiderin, or iron containing pigment. What's another one that we see?
Foreign bodies, like filler.
Yes. Are they usually dark like this though? You hope not, right? You hope. I guess it could be a foreign body if it's like one of these. Yeah, it could be those vegetable tattoo things on
Right.
people. That's foreign material. What's the other foreign material that looks dark like this?
Ink, tattoo ink.
Yeah, tattoo ink. Also carbon, right?
Mhm.
Pencil lead. Somebody stabs themselves, and they get a pencil lead tattoo. Or
Yes.
what's another one that gives you dark pigment?
Calcium, but it'd be more purple.
Yeah, that's usually not brownish black like this, grayish in a way.
Moncel solution.
Blood cells, which is iron. Yeah, ferrous subsulfate. What if you take a certain drug for a long period of time?
Minocycline.
Cycling pigmentation, which actually kind of has this sort of slightly blackish gray color to it a little bit. It doesn't look exactly like melanin, although it's got melanin in there. It's also kind of a combination of melanin plus the drug. It actually stains positively with iron stains too, interestingly enough. There's a couple other pigments though that you need to know. There's this pigment that we haven't named yet. Duty. So you're learning something like I did back in the day. You learn more when you get out and practice, by the way, than you do our residency program. Different kind of learning. It's more like experiential learning, but you will learn more in your first year out in practice than you learn in the last 2 years of residency. I promise you.
That's good. I have a lot to learn.
We all do. I'm still learning today.
Lipofuscin.
Excellent. Lipofuscin pigment. Exactly. That's what this is in this case. And sometimes the secretion from the eccrine or apocrine material, it's got lipid in it, and that lipid oxidizes and it becomes dark like this. So this is sort of like rancid butter that's taken on a, brownish discolored appearance. And so when I saw this shave biopsy, I didn't have any lining like you have here. That's really the hydrocystoma. I just had this. I said, oh my goodness, this could be, maybe regressed melanoma. something like that. So I kind of raised that specter, and oh boy, did the doctor call me up in a flash and talk about this. Do you know who this is? I said, no, at the time I didn't know who the guy was. And so I said, oh my goodness. So he came actually to see me in the clinic, the billionaire, and I looked at him and said, this is nothing, thank goodness. And we then kept some, we took removed the whole thing, took a little, minor excision, got it out. And then we were able to tell that this was actually kind of a part of a cyst. So this is just an example of a hydrocystoma that's got lipofuscin pigment in it that, at least to me years ago, simulated a melanocytic lesion. So so that's the thing. That's the lesson here, is when you get these pigments in the skin, you have to have a differential diagnosis in your mind about what's actually causing it. And I'd say one of the most common pigments we're seeing today are people that are now taking these these new drugs for melanoma, the checkpoint inhibitors, and they have melanoma and they get so-called tumoral melanosis. We had a really nice lecture, Jennifer Gill, who's been studying this here in our institution, has really shown that, when I was trained, I was told, if you have this stuff, you get like a metastatic, satellite metastasis of melanoma, even if it undergoes regression, that patient's going to die. Well, not necessarily today. Things have changed. And so our prognosis of those patients, when they get a checkpoint inhibitor and they develop like a puddle of melanin in the dermis, probably doesn't even have any residual melanocytes in there, it's not always a death sentence. So things have changed, and patients can live with metastatic melanoma, satellite metastases melanoma for a long time now. So that's actually the good news about some of the things we got. But this is a really good example, and a good working through the differential diagnosis of different pigments. You may get asked that on the board examination. Other things that can cause pigment, remember the dermatiaceous fungal infections. So, they may show you an example of tinea nigra in the cornified layer. Exogenous pigments like silver nitrate, argyria. People that get these piercings and things, they get secondary cutaneous, they get localized traumatic argyria, not systemic argyria from taking those drops with silver in it and that sort of thing. So just know your pigments, because you may get asked some questions about that on the exam. And know the stains that bring it out also.
That was really interesting. Thank you.
You're welcome. Good job.
Thanks.
Okay, this is another nice example. Got some really pretty biopsies for you guys today.
Yes, some
A
good
plus.
dermatologists.
A+, yeah, gold star biopsies here.
Yes. So looks like maybe the dermatologist took a punch biopsy and then kind of shelled out this nodule that was looks like it was in the subcutaneous tissue.
Yeah, good. I think that's probably right, or it could have been one of these sort of incisional biopsies or whatever. So, yeah, absolutely. So once again, low power, think inflammatory or neoplastic, or maybe both.
Yeah, it looks very well circumscribed. So from this power, I would favor a neoplasm, but it does have kind of this almost like a pattern of lymphoid cells that it looks like throughout. So.
Okay, good. So if it's a neoplasm, it's certainly going to be almost always benign. Now, what's the exception to the rule of where something can look well circumscribed, but it's really malignant?
I guess like if we were to go on higher power and there was a lot of like mitotic figures.
Yeah, well, that's what you would see. You're right. But at low power, what's the exception to the rule that if it looks well circumscribed and it's not actually benign, it's really malignant?
Not sure what you're going for.
Yeah, it's kind of guess what I'm read my mind, but metastases.
Oh, okay.
Sometimes
makes sense.
Mets, they give
Yeah.
you kind of a cannonball round lesion in the skin. And you look at it and say, oh, low power looks benign. And look at higher magnification. Oh my God, that's filled with atypical cells. It's actually asymmetrical and whatnot. So that's just the situation. That's just remember that we always talk about, well, if it looks well circumcised, it's going to be benign. Well, not always. Most of the time, yes, but sometimes no. So let's take a look at this. We do think it's probably benign. It could be a neoplasm, but you said there's lymphoid aggregations in there as well. So a lot of times, remember, neoplasms can become inflamed.
Yes.
So that doesn't mean that it's inflammatory necessarily, but sometimes there are lesions that may be comprised of two different components to it.
Absolutely.
Lymphadenoma, for example, that's got epithelium and lymphocytes in it. It's got both. So it's kind of got a combination. So what about here?
So, from this power, we're seeing a lot of extravasated red blood cells in the middle here.
Okay.
And then, all these kind of endothelial cells that look like they're, making blood vessels.
Yeah, there are blood vessels here.
Mhm.
Lots of them.
Yes.
Lots of blood vessels. Extravasated erythrocytes. Okay.
Um,
And you talked about the endothelial cells. Any comment about those?
yeah, they're very plump. They
Yeah.
almost kind of look like epithelial cells, like
Yeah,
endothelial.
they
Yeah.
kind of do. Good point. And they look like they're really protruding into the lumen of these little vascular spaces here. What about the thickness of the walls of these blood vessels here?
I mean,
Normal or
here,
abnormal?
here they look kind of like thick.
Yeah, good, excellent. And then what kind of, you said they're extravasated erythrocytes. Anything else you see here that strikes your,
Yes. So there's also a lot of eosinophils.
okay. Now what do we think about when you put all those things together?
Yeah, so if we're in the vascular neoplasm chapter and we have all of this eosinophilia, that brought me down to the angiolymphoid hyperplasia with eosinophilia.
Good, excellent. And that's the diagnosis here, angiolymphoid hyperplasia with eosinophilia. Now let's talk, and this look at this blood vessel right here. This is a classic blood vessel that we see associated with this entity. Very thick walled,
Yeah.
lots of these prominent endothelial cells in here, these vacuolations of the endothelial cells here, and then the eosinophils here. I mean, this is just a beautiful example of this entity. Now, tell us a little bit about the disease. What's the pathophysiology? What's thought to be going on here in this entity?
So the reason that the disease forms, I'm not 100% sure. I mean, I know it's a vascular neoplasm, but there was also discussion like, is this inflammatory versus neoplasm?
Very good. Very, very good. That's the whole thing. So a lot of people think this is a reactive process.
Mhm.
And what are the two clinical settings where we see this histology? Two clinical scenarios.
So like, I know more like younger, middle-aged people, usually on like the head and neck.
Good. Ear's a common location for that. Come in and usually the clinician doesn't know what it is. They send an in biopsy, rule out, cancer or something like that, and they get this back. There may be some history of some kind of trauma or something like that in that area, maybe not.
Mhm.
And then what's the other scenario?
There was another disease I read about, and I don't know if that's what you're getting for, the Kimura disease.
Yes, Kimura's disease. Now, how does that differ from that other scenario?
It was like on the posterior neck, I believe, a lot bigger and deeper.
Well, a lot of times there are deeper lesions like this. This actually could be from somebody with Kimura's disease.
Right, this is big.
Why is it called Kimura's disease?
I mean, I know it also had associated kidney abnormalities.
But the reason it's called Kimura's is because it's usually seen in Asian,
Oh, yes, okay.
more commonly seen in
Yeah.
Asian men, actually, interestingly enough. And of course, Kimura was a Japanese doctor, obviously, who described this. So basically, just remember those two scenarios. Histologically, looks pretty similar. And I haven't really seen too many biopsies of bona fide Kimuras. We don't get that many patients over here that have the disease. It seems to be more localized there. Some people have postulated that may be related to some kind of a infection or something like that that's endemic to that area, sort of like Phogosolagem's endemic down in Brazil or whatever. No one really knows exactly, but it's far more common there. This we see relatively commonly in the United States. Not super common, but I'll say we see a few cases of this a year. It's not vanishingly rare. So you just have to think about it. And obviously you're going to have to take a biopsy that gets deep to the skin if it's going to be a deep nodular lesion like this. So they didn't think about the diagnosis. This also was thought to be a cyst here. It turned out to be this. Sometimes you see this with the classic vascular pattern with very few eosinophils in the actual lesion, yet they may have circulating eosinophils. So it's not always eosinophils in the lesion. Sometimes it's in the bloodstream. Interesting enough. So very good. That's excellent. Glad you got that. So again, if you're going to see this on a board examination, some of the things they're going to toss in there for you to kind of have to distinguish. They're going to say A, angiolymphoma hyperplasia of the eosinophilia, B, Kaposi sarcoma. Okay, you're not going to say that, right?
No.
Never. You would never see EOS. What kind of cell do you see in Kaposi's?
Oh, Kaposi's is it, oh my gosh. My
It's on the
mind.
tip of your tongue. You're about to say it.
It's not plasma cells.
Yes, it is. It is. Plasma cells. Good. Excellent. Bacillary angiomatosis. Are they going to put that on there?
And I'm not going to choose it.
I'm going to choose. Why not? Why not that?
Oh gosh, I don't know.
Well, a couple of reasons. First of all, you don't get the blood vessels with the big, thick endothelial cells. It kind of looks more like a lobular capillary proliferation, like a pyogenic granuloma with edematous stroma. And what kind of inflammatory cells are most common in that entity?
I mean, it's bacteria, so like overall causing the disease, right? So would it be, gosh, like histiocytes maybe, or
Neutrophils.
neutrophils? Oh, that makes sense.
Polys.
Yes,
Okay, they
yes.
get that Pileus hepatis, abscesses and stuff like that in their liver. So neutrophils, BA, eosinophils, this, plasma cells, Kaposi's. They wouldn't, they might put like a weird angiosarcoma, but I doubt it. And they're not going to ask you about things like hemangioendotheliomas or anything like that. So just remember those kind of pearls and you'll have no trouble with that. Okay, this one's kind of cool also. This one could end up on the board.
Good morning, Dr. Cockrell. I'll be taking this one.
Okay,
So it looks like we have a shape of a pedunculated papule, possibly
Good.
like a warty looking polyp.
good, good. Warty, excellent. What's the other name for warty?
Papillomatous.
Sort of.
Or
But
like
there's yet another name. There's yet another name for it. What's the, yeah, verrucous. Good. That's the Latin term for wart. I think there wasn't the girl in the Willy Wonka's chocolate factory, wasn't she named Veruca or something like that? So,
Yes, verruca salt. And from this far away, it looks like it's probably a neoplastic process going on.
good. Epithelial or non-epithelial?
Epithelial,
Good. And benign or malignant?
benign.
Obviously benign. Look at this. Okay, let's go to higher magnification. So do you think it's a wart?
I think that from afar, it could have been maybe mistaken as a wart.
Yeah,
But
that's one of the, I mean, if I saw this at low power, that'd be one of the first things I would think about. What's a
Yeah.
little funny for wart though, when you go to higher magnification?
it has these really, really long kind of like branching reedy ridges.
Yeah, that's a
And-
little unusual. You can see that in some warts, like in, for example, in plantar warts and verrucous carcinoma, you can get these very elongated epidermal rhesia that extend pretty deeply down into the dermis. And in fact, that's really kind of one of the ways you make the diagnosis of verrucous carcinoma is just a deep extension into the soft tissues and whatnot, because it doesn't really have a lot of cytologic atypia. It's really more of a neoplasm that's malignant because of its local destructive effect. But what
Mhm.
about the outer part of the epidermis? This is kind of an unusual finding here, isn't it?
We've got
What's
a
that all
lot
about?
of like parakeratosis
And
and
what about this? This is
yeah.
a helpful clue to this diagnosis, by the way.
These cells look like they're kind of like darkened and like almost granular looking.
Yeah, notice how pale and pink this is?
Yes.
And look at all these neutrophils up here. So what do you think's happening there? Why does it look like this? That's not normal. And
I
you may
think-
not know, but that's okay. If you don't know, that's fine.
I think that kind of with like the pathology of this, maybe it's kind of like the body reacting to the process going on down in the dermis.
Well, actually, this probably comes first, and this may come second. It depends on who you believe and whatnot. This is maceration. So if I
Okay.
took your skin and, put something on there that irritated the heck out of it, it would develop, instead of being a nice cornified layer with basket weed features and, granular cell layer and be purple, it turns pink like this. and it gets
Mhm.
neutrophils up here. So this is almost like an irritant macerated skin here. And where,
Gotcha.
and do you, so you said something in the dermis. What did you see in the dermis here?
So in the dermis, we've got these papillae extending up, and we see these cells that look very kind of clear with these spaces, almost like they're filled with a lipid and
Good.
could potentially show me histiocytes.
Yeah, that's exactly what they are. These are histiocytes filled with some lipid material. So what's the diagnosis here?
I think this is a verruciform or a verruci, sorry.
Keep going. You're close. You're close.
Verruciform xanthoma.
Cruciform xanthoma. Good. That's the diagnosis. That's exactly what this is. Beautiful. So where do these occur most commonly?
They can occur predominantly in the mouth or in the genital area.
Good. More commonly in the genital area, I would say. I've seen a few in the mouth. Yeah, you're right. But it's mostly the genitalia. And a lot of people think that's what's happening here is the skin in that area. It's hot, moist, gets irritated, macerated, and that this is really not a true xanthoma, that it's really more of a reaction pattern to chronic trauma with epithelial hyperplasia, maceration, neutrophils, crust, secondary influx of histiocytes, fill up with lipid, and then you get this lesion that forms, and as a consequence. So what's another disorder that occurs in the groin area that gives you a lot of verrucous epithelial hyperplasia, some crusting, some inflammation, but doesn't give you the xanthoma cells?
Like a condyloma acuminata.
Well, that would be possible, but what if it's like a baby?
Mm,
And maybe the mom hadn't been taking really good care of the kid and changed the diapers as frequently as they should have been.
mm. Like
Like
a
Jacquet's dermatitis, right? That those papular lesions that little kiddos get down in the genital area from maceration and inflammation. It's just chronic diaper dermatitis. When you really get that florid and it really gets extremely inflamed and whatnot, that gives you kind of more like a granulation tissue response. It's almost kind of like a pyogenic granuloma-like reaction associated with severe irritant dermatitis. And you can see similar reaction patterns like that in people with chronic stasis dermatitis. It really gets bad. Just chronic maceration can lead to granulation tissue response, inflammation, and then in some cases it actually can give you these foamy histiocytes in here. So
Mhm.
this is verruciform xanthoma. A lot of people, just like they think angular lymphatic hyperplasia may be a reaction pattern, a lot of people think this disease also is a reaction pattern and not really a true neoplasm. So that's good that you got this. So just remember that's and always look if you see something that looks like there's a lot of maceration or warty changes, look here. Don't just ignore this, because that may be the diagnosis that they're asking you for here at the xanthoma. Now, is this associated with any lipid abnormalities? That might
It's
be.
actually not.
No, this is just a reaction. It's not anything. Their lipids are perfectly normal. It's probably just a secondary reaction. The only other place you can actually see this kind of reaction pattern change is actually in Fox-Fordyce disease, interestingly enough. That's probably more inflammation with apocrine glandular epithelium that probably releases some of the lipid from the apocrine cells, and then these histiocytes come in and engulf it, and it gives you this sort of verruciform xanthoma-like change to the edge of the apocrine gland. So you can see that sometimes there too. All
Thank
right,
you.
very good.
Hi there, I'll get this one.
Okay,
So we're looking at so from this view, I'm already thinking, okay, square punch differential, see some deposition in the superficial to mid epidermis. But then at a higher view, you see an unremarkable sternocorium, sort of a thinned out epi in some areas. The
Good.
pathology
so
seems
that
to be
thinned out epidermis, tell me a little bit about that.
just some atrophic epidermis.
Very atrophic epidermis. Okay, that's
Mhm.
good. So this is inflammatory, right?
Mm-hmm.
What's the pattern that we see here?
Yeah, so I don't see much inflammatory cells. It's pretty concentrated around where that mucin is and some
Good,
around the
there's
deepest
excellent. There is mucin here. You've got some inflammation down here.
structures in the bottom.
And as we look, let's go back to the epidermis and look at that. Okay. So that's very thin. Do you see anything else about that epidermis that's very thin here?
Anything else about that? But like the
What's this?
sorry, I can't even see the arrow. Sorry, one second.
Oh, I'm sorry, you can't see that. Well, look right beneath the 3-cell layer epidermis.
Oh.
What's that pinkish material right in that area?
Oh, so just like the hyalinized, or sorry, sclerotic collagen.
Well, this below is sclerotic collagen. But right beneath the epidermis, what lives right there? Right at the base of
Like the
epidermis?
basal cells?
What's right beneath the basal cell layer?
Um,
At the electron microscopy level.
oh, like like the I don't know if I understand what you're like the basement membrane.
Yeah, the basement
Okay.
membrane, the basement membrane.
Okay.
Normally, you can't really see the basement membrane, right?
Uh-huh.
But here you can see it. It's pink and it's thick. So what do you think about what disease does that sort of call to mind when you see a thickened basement membrane zone coupled with a very thin epidermis?
Could think of dermato and lupus. And I
Well,
guess
okay, right, good. Which of those two is more commonly associated with a thickened basement membrane zone?
dermato. Lupus.
Good try. Lupus. Lupus is good, but you were close. You were very close. Okay, so let's see if we can figure this out. What about these? You said there's mucin in here, thickened sclerotic collagen. Let's look
Mhm.
down here at subcutaneous fat, and we've got what kind of cells do we have here?
So over there we have lots of lymphs and plasma cells.
Good, we got lymphocytes and plasma cells here,
Mhm.
and mucin.
Mucin, yes.
So
Mucin,
how do you put this together?
well, putting that together, I was actually thinking about the square punch differential in the beginning.
Well, good, that's, yeah, so what is the differential diagnosis of the square
Mhm.
punch?
So
Yeah.
you can have scleroderma morphea, which is what I kind of thought this originally was.
Okay, what's not so great about that?
I don't know if you'd expect this much mucin.
You would not.
Yeah.
Good. You
and
would
that
not.
Diagnosis.
Would you expect a thin epidermis with a thick basement membrane zone?
Yes, and you would also.
Oh, you wait a minute. You would in morphia?
Oh, no, would not, sorry, but
Good,
you would
you
expect
would
the
not.
square punch and the deep infiltrate in the sub-Q.
Good. You would not think that. Now you can see this in morphia for sure. You can see lymphocytes and plasma cells at the edge of these the lipocytes here, the lobules. So you can see that, but you've got some funny features here, don't you? You've got this thin epidermis. You've got maybe a follicular plug here. You've got the thick
Think of
basement membrane
discoid
zone.
lupus.
So you lupus. Okay. So how do we, what do we, how do we put 2 and 2 together? Is this what you commonly see in lupus?
I don't know if we would see as much sclerotic collagen in lupus either, unless
can
maybe
you?
it's like chronic. Yes, you can.
Can you see it
Mhm.
sometimes? You can. So that's one of the teaching points of this case is that it looks like scleroderma, but it's got confounding variables. It's
I
got
guess
features of lupus up here. It's got the mucin, which you don't see in that. So this is what we call one of the so-called
fungus.
overlap disorders.
Mhm.
Overlap between lupus and scleroderma.
Gotcha.
So this is basically, this patient had discoid LE. When they biopsied it, had the sclerotic collagen in there, which is unusual for discoid lupus like this. Didn't have much inflammation anymore. So sometimes, you'll get the lymphocytic infiltrates and you'll get the thinning in the epidermis, the mucin, all that kind of stuff. Some cases you get this. So just understand that there's several different overlaps. What are some other, what's another overlap between scleroderma or sclerotic processes and another connective tissue disease that we see sometimes?
just like other things off the square punch differential or like other sclerodermic, like scleromyxedema, scleroderma, or sclerodema diabeticorum, but those are more depositional than
Yeah, those
sclerotic
really are, yeah,
diseases.
exactly. Those
You
really
could
don't
get
fit.
GVHD with like the dermoid kind.
That could possibly fit in here. I would buy that.
Um,
But the thing that with the sort of the read my mind question I'm asking is more connective tissue diseases that we think of, like interface dermatitis, for example, that have sclerosis. So the other big one, obviously, is, you get like so-called mixed connective tissue disease.
mhm.
It's a lot like scleroderma, but sometimes you can get some interface change with that. Sclerodermatomyositis is the other one.
Oh, okay.
Patient with dermatomyositis, got known dermatomyositis, 100%, they got, elevated muscle enzyme levels, they're weak. They might even have an underlying cancer. And they got reticulated poikiloderma. And sometimes you biopsy, their skin feels kind of firm and sclerotic. You biopsy, it looks like this also. This could be sclerodermatomyositis. In this case, the patient they had lupus for sure and had sclerotic changes, but sometimes you'll see dermatomyositis that can get sclerotic changes. So basically just understand that the way these connective tissue diseases, they don't always look like the classic obvious features in the textbook. Sometimes they can have secondary changes, like this is lupus with a lot of scleroderma-like changes.
Gotcha.
So that's just kind of the teaching point of this case.
Tricky. Thank you.
And it's interesting because it might even have a tiny bit of lupus paniculitis down here. you see that?
That was on my
That's getting
differential as
degenerated.
well.
So good. All right.
Thank you.
You're welcome.
So I got this one, Dr. Cockerell.
Okay, great.
So yeah,
Let's grade this biopsy.
yeah, it's definitely a shave. Low power. There's like some perivascular kind of.
Let's give it a grade first. Do you think it's inflammatory or neoplastic?
I would say inflammatory.
Yeah. Do we like shaves of inflammatory things?
No.
No, we give it an F. We're not gonna buy that. We wish we had a biopsy like the next case. We didn't get that here. So we're sort of have to, one arm's tied behind our back a little bit, but go ahead. We can do it. We're tough. We can do it anyway, right? So you think it's inflammatory. What pattern? About superficial and deep?
I can't rule out deep. That's true.
Yeah, that's why we don't like it. That's the reason we don't like it, because that's one of the things we want to assess. We can't look down here. What if it had vasculitis there? What if it had paniculitis? Thank you for giving us only a part of the picture. But anyway, what do you see?
So I see a little bit of like the hyperkeratosis. There's a little bit of para in there. It looks like there might be a little bit of either sponge or interface just from this view in the epi. And then definitely I see kind of this perivascular infiltrate. Can't say cell types from this view.
Well, you can kind of say a little bit.
Maybe
right?
Lymphocytic.
Yeah, it got to be at least some lymphocytes because they're black. Now, you're right. There may be some others we go down there. So we've got at least superficial perivascular dermatitis. We've got an abnormal epidermis. We got abnormal cortified layer. Let's talk about the abnormality of the epidermis. Tell me a little bit about this. Last one, we just had markedly thinned epidermis. What do we have here?
Yeah, it's areas of acanthosis as well.
Okay, so we call that psoriasiform epidermal hyperplasia. Now, there's two types of that, right?
Yes.
There's the regular type, and then there's the irregular type. And so would you call this more regular psoriasiform epidermal hyperplasia or irregular psoriasiform epidermal hyperplasia?
I would say pretty regular.
Well, when you say regular, we usually mean, cookie cutters, like every single epidermal reedy looks like the other one. Do these all look like identical twins here, or they look sort of like not identical twins?
Yeah. Okay. So then, it'd be irregular in this case.
Irregular, yeah. Now, in psoriasis vulgaris, you get elongated epidermal reedy with thin suprapapillary plates and dilated tortuous blood vessels. Are these that here?
I don't see as many dilated blood vessels in the papillary dermis.
Oh, good. You don't get thin suprapapillary plates here either. Notice these epidermaricia, they need to go on a diet. They're pretty fat, right? They're plump. They almost kind of join together. in a couple of places here. So they're a little plumpy, fatty epidermal rete here, not like we see in classic psoriasis, right? Because psoriasis dermatitis, we don't have the classic psoriasis features. What's going on here?
There's some areas of like acanthosis.
What about?
Sorry,
Yes,
acantholytic.
acantholysis. Good.
yeah.
What's that mean?
There's just some separation between like the keratinocytes.
Do we just say this doesn't mean anything? It's not going to help us any. We don't care about this. Just maybe it's a histologic artifact. We're going to just blow it off, or do we think it might help us with the diagnosis?
So, I mean, at this point, it's only in that one area, and I don't see any like disc keratosis with the acantholysis. So I wasn't really sure. I was thinking it might have been artifact.
Okay. Well, we'll talk about that in a minute. So what about the cornified layer? You mentioned it. Tell us
Yeah.
about that.
There's some areas of like parakeratosis in there.
Yep. Is it diffuse or localized?
So it skips. I think in some areas, I think didn't have as much, but for the
Yeah,
most
okay.
part, it's
Here it is, goes away, comes
yeah.
back here. Here it is, goes away, comes back here. What do we call that?
Alternating ortho and
Yes, the so-called checkerboard pattern of parakeratosis. So you put all that together, what's the diagnosis?
I mean, you can get the checkerboard with like actinic keratoses, or
Is this an actinic keratosis?
I don't think so.
No, absolutely not. There's no atypia here. There's no sparing of the follicles or anything like that. So it's not actinic keratosis. So what is the diagnosis here based on those findings that we've described? The psoriasis.
Oh yeah, I guess with PRP with kind of the
PRP.
psoriasiform and yeah.
Good. This is PRP. It's classic. It's beautiful. The only thing I wish they had was a punch biopsy. We didn't give us a punch biopsy, but they gave us a shave. At least we can make the diagnosis based on this. Now let's go back to this. So you think this doesn't mean anything?
Yeah, given kind of, I guess, like the idea for PRP, no, I think this is consistent.
You see this in PRP. And I have another old age story that I can tell you real quick, that I remember when I first encountered this back, I think it's about 1989 also, and got a biopsy. I cited that as Grover's disease when I saw this. I didn't pay attention to this. I saw this, I focused on that. And so the clinician sent the patient to my clinic with the biopsy paper, and he written on there, "You tell me if this is Grover's disease." The guy came in quasi-erythrodermic, classic PRP, and it had the acantholysis that I focused on because I didn't pay attention to this because you don't see acantholysis PRP. The week after I saw the patient, there actually an article came in the American Journal of Dermatopathology, PRP associated with acantholysis, and I'd never seen it before. So this is actually something now that can be kind of helpful. So you see it very commonly in PRP. It's not a histologic artifact. We do see acantholysis in PRP in some cases. And at the time I didn't know it. I revised my diagnosis after that the guy had obvious PRP and histologically he had these other features, but I said, maybe that's just some background psoriasis stuff, because this to me I thought was prominent, and it actually turns out to be associated with PRP. So it's actually be a helpful finding sometimes. So very good. I mean, it's beautiful. I mean, it just has all the features for everything we talked about. The one thing that you can sometimes see in PRP, don't let it throw you, is occasionally get some eosinophils in the infiltrate. You can sometimes get some spongiosis. So those are things that you can see. But when you get this alternating parakeratosis, ortho, both vertical and horizontally like this, coupled with these epidermal changes, and if you see this, that's helpful. You've got the diagnosis. All right, any
Okay, great.
questions?
No, that was helpful. It's a good clue. Thank you.
We didn't get the last one. You guys have to probably go, but it's a good one too. So I strongly recommend looking at this one. This is a great case. Maybe we'll bring it back and discuss it next time because it's really beautiful biopsy and shows great features. All right. Well, thank you guys for your attendance and participation. Maybe I'll run into you guys at the AAD meeting. Enjoy it and learn something.